Well, good morning, everyone. Why don't we go ahead and get started? I can see people are joining. I'm Lydia Chwosiak. I'm a psychiatrist and a professor in the Department of Psychiatry at the University of Washington School of Medicine, and I am one of the co-directors of the Northwest Mental Health Technology Transfer Center. And I'd like to welcome everyone to today's webinar on behalf of our Northwest MHTTC and also on behalf of our partner, the Behavioral Health Institute at Harborview. Today's webinar, Introduction to Telehealth, Myths and Facts, is the second webinar in a series that aims to support community-based behavioral health providers in Washington in their implementation of telehealth services. We appreciate that the capacity to provide effective telehealth treatment has become an urgent issue in the context of COVID-19. And we know there are a lot of questions as organizations are ramping up services on a very accelerated timeline. We had a terrific first session on Wednesday, and I'm delighted to welcome our panel back today. Just a reminder that we're structuring the series so that Wednesday sessions will focus on administrative and technical issues, and these Friday sessions will be more clinically oriented. So just to kind of bear that in mind as we go through the next couple of weeks. As on Wednesday, we're aiming to structure these sessions so that most of our time will be dedicated to discussion and question and answer with our expert panelists. Gabriel, can we go to the next slide just to describe the MHTTC network? For those of you who aren't familiar with our work, we are part of a national network that's funded by SAMHSA to support the behavioral health workforce to implement evidence-based practices for mental health disorders. Our Northwest MHTTC is based in the Department of Psychiatry at UW. We're up in the Pacific Northwest, and we provide training and technical assistance to the Region 10 providers, Alaska, Idaho, Oregon, and Washington. Broadly, our goals are for the MHTTC are on the next slide, and that's to heighten the awareness, knowledge, and skills of the workforce in addressing the needs of individuals with serious mental illness, and to accelerate the adoption and implementation of mental health related evidence-based practices across Region 10. We also have a goal to ensure the availability of free training to our behavioral health workforce. So all of our trainings are free. On the next slide, just a reminder that it's always our intention to use language that promotes recovery and culturally appropriate terminology. We encourage all of our panelists and participants to use person-first language, which emphasizes the individual and not a condition or disability. This is consistent with recovery-oriented practices and promotes treatment and training environments that foster respect, human dignity, and hope. So we have before we get started, we have a few logistics to review. Just as you're all getting very familiar with Zoom, just a reminder that there is a chat box on your screen, and what we are using the chat box. If you have a technical issue related to participating in the webinar, please chat your question or issue into the chat box, and one of our staff will respond to you and help troubleshoot the technical issue. The chat is not a place for your content questions, so please don't put content related questions into the chat box. Instead, there is a Q&A button that you have that you can type in your question into the Q&A window. As I said, the primary goal of these sessions is for our panelists to hear your questions and try to help you address any challenges that you're facing with telehealth right now. So because we're a large group on the webinar, you're all muted. So there are two ways that you can ask a question in this session. You can type your question into the Q&A window, or you can raise your hand and one of the panelists will unmute you so that you can ask your question. We're going to start the session with a brief didactic session by Dr. Brad Felker. This session is short, so we'll not interrupt for Dr. Felker for questions, but then we will have 30 minutes at the end of the session for Dr. Felker and the rest of the panel to answer questions. So I'll be monitoring the Q&A box and try to facilitate answering as many of the questions as possible, but you know, we are unlikely to get to all of the questions today, so we'll do our best. Our goal is to rapidly incorporate your feedback into subsequent sessions in this series. So another opportunity for you to provide feedback, as shown on the next slide, is to respond to a short survey at the end. So we'll, near the end of the session, we'll share the the survey link in the chat box. We'll also send it to you by email. We're required by SAMHSA to conduct this survey, and your participation helps to support future free trainings like this series. So we'll give you some time at the end of the session to complete this survey. Just a reminder that we're not able to provide certificates or CEUs for this series, but the slides and other resources will be posted on our website and the BHI website after this session. The next slide, just to remind everyone of our panel, the same group of wonderful experts from the Wednesday session. They'll be with us through the series. They provide a broad range of expertise in technical, administrative, billing, and policy issues. The focus today, though, is on clinical care, and I'm really delighted to introduce our presenter today, Dr. Brad Felker, who is a close colleague. He's a professor in our UW Department of Psychiatry and a psychiatrist at the Veterans Affairs Hospital in Seattle. Dr. Felker is dually trained in psychiatry and internal medicine, and his career has focused on health services research and integrated care. He is a national expert on telehealth, and he developed and led the telemental health service at the VA Puget Sound in Seattle. And he's trained a generation of UW psychiatry residents and fellows, and now faculty in telemental health. So I'm going to turn it over to Melody McKee from the Behavioral Health Institute to say a few words about the Behavioral Health Institute, and then turn it on to Dr. Felker.
Good morning, everybody. Glad to see you all here today. Just a quick word about the Behavioral Health Institute and our Training Workforce and Policy Innovation Center. We are partnering with the Northwest MHTTC to provide some statewide training around telehealth currently, but the long-term vision is to stand up a statewide infrastructure that supports training, workforce, and policy. And I'm ready to hand it over to Dr. Felker.
How about the first slide? There we go. Well, good morning, everyone. What a pleasure. It's a pleasure to be here, and I want to thank everyone for this opportunity to speak during this challenging time. It is our sincere hope that we can provide you with some very useful information as many of you are going forward to set up your own telehealth programs, mental health programs. Over the next several weeks, we're trying to provide you guys with some core information that you might find useful to get started. Some of you might know this already, but bear with us. We want to kind of provide this base information so that we really don't leave anyone behind. We really hope to sort of lay a foundation upon which we can build later on as this series goes forward. And we want to be able to build this series based upon what you need and what you want. So we really need your feedback. That's really valuable to us, because if you don't provide us feedback, then we're going to assume. And you know what happens when you assume, and we don't want that to happen. So today's talk is about myths and facts around clinical video teleconferencing, and that's what CVT stands for. And I'll talk more about that in a moment. You might ask, why are you guys talking about this now? Well, over the years, I've been fortunate enough to work with some great people to do a lot of program design and implementation and evaluation. And when you're starting a new program, you can really think about the barriers you got to get around. And those barriers can be kind of grouped into three big categories: patient related, administrative related, and provider related. And sort of, I think most people, and certainly my experience is, patient related barriers, those are the easiest to get by. Most patients will say, wow, you mean I can get what I need and get out of here and about my day? I'm in, let's do it. And then administrators are sort of your next layer of barriers. And usually what I hear from them is something along the lines of, so you're telling me this program will help my performance measures and I'll look better? Let's do it. I tell you, the hardest barrier to surmount is always sort of provider related. And that's nothing against providers, but providers come from so many different schools of training, and they're doing the direct clinical care. That's really important to them. They've developed successful routines. So asking them to make cultural changes in the way they do business can be really difficult. So that's why when we're talking about setting up a telehealth program, I like to sort of start off with sort of a brief review of the literature, to sort of address right up from the start concerns providers, administrators, others might have, and what is some of the literature that kind of help people understand this. Next slide. So here are today's objectives. We're going to just to add some context, we're going to just do a quick history of telehealth. Then we're going to review some common myths associated with CVT, or clinical video teleconferencing. And this is not going to be an exhaustive review of the literature. I'm going to offer what I think are some good papers. The references will be there. The slides will be made available at the website. So you can pull the references from there. Or if people want, we can just post all the papers up on the website if that would be easier for you. Next slide, please. Okay, the disclaimer slide. So I guess this is where I say I'm not a lawyer and I don't play one on TV. So always consult with your legal counsel. Today's talk is just purely advice, and we'll move forward from there. Next slide. Okay, so today we're going to focus on clinical video teleconferencing, or CVT. Why are we talking about that? Well, most people, when they think about telehealth, this is what they think about: clinical video teleconferencing, FaceTime, Skype, whatever you want to talk about it. But I would challenge you guys to be thinking forward beyond CVT. I mean, we're talking about CVT today, I get it. But really, CVT is just one of many digital health modalities that are quickly becoming available to us. And those other modalities include apps, web-based training, phone care management using computer-aided telephone interviewing, secure emailing, texting. Providers are starting to text with patients. And then there's a whole nother layer to think about: how do you integrate these new modalities into routine mental health care? And then if you really are bored, you can start thinking about how might these modalities change the way we deliver healthcare going into the future, and how are we going to train people to do all this? But today it's going to be about CVT. However, in your feedback, if you want us to touch base on how you might want to incorporate and integrate these other modalities, let us know. We'll set that up for you. No problem. Next slide, please. Okay, let's do a little history. I love sharing this picture. Okay, telehealth has actually been around for a long time. This is 1959, and it got started in Nebraska. And check out the dude on the TV. No wonder. I've often thought this is the core image of why stereotypic pictures of what psychiatrists look like. But anyway, this is the original sort of setup in Nebraska. You had the psychiatrist on the TV there. You can see the camera, old school camera, what today would be a webcam. And those are actually trainees. Those are not patients. But this is a slide just to say, telehealth has actually been around for a long time. Next slide, please. So we're going to do just a quick overview here. What really has been holding up telehealth initially was the technology. So you started to see some traction being gained with improvement in technology in the 1970s, when people started to get some initial funding around this. In the 80s, with computers really starting to come into play, that's when things really started taking off. And then it really started going international. It started mainly in the United States. But interesting, some of the seminal work, really great work, was coming out of Australia. And I think that was mainly because of their rural base. And then we launch into the 2000s, and we've really seen an explosion around CVT, the other modalities, what with the faster internet, better quality cameras, audio, all types of operations. And what's been prior to COVID, what was holding up up now was really more policies. Whereas in the 70s and 80s, it was the technology that was holding things up. More recently, the technology has been moving so fast. It was policies, billing, reimbursement, rules around prescribing, particularly prescribing controlled substances, which is tricky. We'll want to touch base on that at some point. Now, COVID is a terrible, terrible thing. I'll be the first to admit all of that. But from a telehealth perspective, it's been interesting that COVID has allowed a lot of these policies and billings to just sort of just blow through them. Hence why we're sort of talking today. So what we're seeing is kind of interesting. You guys may have heard of the Moore rule, which is really sort of held. I'm going to paraphrase it real quickly. Moore was a CEO at Intel, and way back in the 60s, he basically said that the speed of internet, the speed of computers is going to double every 2 years, and the cost is going to be cut in half. And that's kind of sort of still holding true today. So it's going to be interesting as we go forward. It's just going to get faster, more ubiquitous, and fortunately, policies and billing are starting to catch up with everything. Next slide, please. Okay. Oh, okay. It's time for our poll question. So if the person driving the poll question could do their duty, that would be great. Okay. So here's your poll question. In general, when one compares clinical video teleconferencing to in-person face-to-face appointments, all of the following are true, except which one is false? First point, diagnoses via CVT are valid, as valid as those in-person face-to-face. Treatment results delivered via CVT are similar to those delivered by face-to-face. Point 3, the elderly appreciate care delivered via CVT when compared to in-person face-to-face. And finally, when both direct and indirect costs are considered over time, CVT is actually more expensive than delivered via face-to-face. So I'll give you guys some play-by-play analysis now while the results are rolling in. So far, we got 0% for people think that the false answer is CVT is as valid as face-to-face. We have only 2% saying treatment results via CVT are similar to those on face-to-face. And then we've got pretty even split that elderly appreciate as false, elderly appreciate care delivered via CVT when compared to in-person face-to-face versus the cost that CVT, when you consider indirect and direct costs over time, that CVT is actually more expensive. So this is interesting results, everyone. You guys are doing great. Good feedback. I feel like I'm announcing a horse race here, and it's a nose, it's a by the nose finish here. And so at the end, really nobody thought diagnoses by a CVT versus face-to-face was that people do feel that that's true. And the next one saying that treatment results delivered by CVT are delivered just as well versus in-person, people felt that was true. But then we have a dead-on split that elderly find it care, they appreciate care just as much as in-person versus CVT, and that the costs are the same. So let's move forward. Why don't you guys close down that poll, and we're going to try and figure out what the answer is to this. So be sure you close this down or you won't be able to see it as we move forward. Next slide, please. So here we go. Let's talk about some facts. Now, I'm going to talk in generalities now by my read of the literature. This is not going to be hardcore results, but just in general. So the first one, myth. Diagnosis, you cannot make a diagnosis by CVT are no way as valid as those done in person. Well, over and over and over again, it's been shown that if you're properly set up and do a proper, intake evaluation, that the evaluations done over CVT are, in fact, just as valid and accurate as those done in person. Okay. And when you're looking at this literature, I want to add that almost all the studies are done using something called non-inferiority methodology. And what do I mean by that? That means that the studies are set up not to show that one modality is better than the other, but is to show that is one modality as good as another. So that's why I set these statements up as they are. I'm not saying that one is better than the other. I'm just saying as good as the other. So as you read this literature, I think it's important to understand that modality. So also, when you look at treatment outcomes, over and over and over again, and pretty much for any mental health condition, as long as you got a quality provider doing quality care, the treatment is as good delivered over CVT as done in person. And there's several literature there we're going to talk about, and we're going to go into the Ruskin paper in a moment because that's really considered a landmark paper. Let me just sort of give you also, so whenever I give a talk, I always like to sort of give my opinion on what the literature says, then also sort of my opinion upon, having done this work for as many years as I have. So I think a lot of the improvements we're seeing are due to the fast internet and the quality of the video that you're seeing now. If you go back just even a few years ago, the video was clunky, it was choppy, the audio exchanges were frustrating, but with the higher speed internet now, it's really quite seamless. And with the video quality is really impressive now. So for example, if I'm working with a patient who's got a psychotic disorder and is on antipsychotic medications, and I want to do an abnormal involuntary movement scale or AIM scale, I feel as a clinician I can do that just as well over video as I can do in person. So that's what the literature tells you. That's one opinion that I have. I'm going to share with you another opinion. This might be a little controversial over what I just said. Now, I was a clinician not doing telehealth for most of my career. And if you were to ask me honestly, well, what do you think, Brad? Do you think that in person is just the same as by video? I would say, honestly, that in person probably is a little better than by video. I adhere to that. That nothing beats having someone sitting in the room with you, being able to observe all the cues, the body language, and all of that. I think it is a little better. However, I would also say that when you consider everything that you can do by telehealth, everything you can do with all these emerging telehealth modalities, this becomes a very powerful tool that you should have in your toolbox, and that you can actually do more. And the analogy I often use is sort of like a handwritten letter versus an email. I don't know about you guys, what you would prefer to receive, but I always prefer to receive a handwritten letter, personal letter. But really, I can't even remember the last time I got a handwritten letter over an email. And why is that? Well, I would suggest that, even though emails are not as nice, they get the job done. The content is exchanged and you can do so much more with it. So that's sort of the analogy I use, kind of clinical video teleconferencing versus in person. Next slide, please. So I promised you I'd dig down a little bit in the Ruskin study because this is really important. This is the kind of the first landmark study that was done, real good quality randomized control trial of in-person versus clinical video teleconferencing. They used outstanding quality outcome measures, ran a really good, it's just a great study, and I'd ask you to take a look at that if you got doubts on this or how to do a good study. And basically it showed that care for depression over CVT was just as good as it was in person. So this is a real important paper, and I just wanted to take a moment on that. Okay, let's move on. Next slide, please. Okay, here's another myth. Elderly don't like it. Oh, you can't get the elderly to do it. They'll never adopt. They're old school, blah, blah, blah. This has been one of the biggest myths I've come across, particularly since I work in the VA. And as you guys know, we sort of have a bimodal population. We have elderly, and then we have a lot of young bucks and does coming back from current wars. And what we've really, the literature will show is that the elderly actually really appreciate CVT and really find it great. They, and that's for a lot of reasons. And my clinical experience is really reflects what the literature shows too. You know, and you stop and think about it for a moment, it starts making sense. You know, elderly do not want to schlep up and down I-5 or wherever, just trying to get to your office across the parking lot. They're aching back for a short appointment. They really want to get on, like everybody else, they want to get on with their lives. They appreciate the convenience of it. They really appreciate, and this is for our rural colleagues on the call, they really appreciate the improved access to other providers and specialists that they might not have access to or might require a drive over the mountains or something like that. I think assuming that they can't use technology is really not fair to them. A lot of them do keep up with technology, and a lot of them have been getting a lot of training from their family. They FaceTime with grandkids and things like that. And so they're very motivated to use tech. They don't want to become isolated, and they've found that they do very well. In fact, it's very rare do I come across an elderly veteran who says, "Doc, just not for me, this newfangled gizmos. Nope, I just don't see it." And what the literature, it was interesting, what the literature will tell you is it's really not generational, that the disparities around who uses these technologies is more related to educational level and income. And that's more predictive about who will actually use the internet and who will not. So next slide, please. Here's another one I hear all the time, particularly when I'm talking to administrators about why they want to be putting in telehealth. And now it's time to answer the question. So I hopefully, you know, going back to our poll question, hopefully you saw that the elderly do appreciate CVT just as much. And here is the false answer. So, all right, what do I know about health economics? Not much. I'll be the very first to admit it. Early on in my health services career, I used to say really dumb things like, well, can't you just say one program's more expensive than the other? And usually the health economists at the table would fall on the floor and have some sort of seizure. And over the years, I've come to appreciate their point of view. Health economics is really complicated, and I defer to them. And so this is a complicated topic. And so if you're thinking about putting in a telehealth program, there's a lot of things you need to take into account. You need to take into account what type of program are you putting in. One telehealth program doesn't fit all. Are you doing, you know, severely mentally ill and an outpatient? Are you doing inpatient? Are you doing ER? Are you doing substance use? Are you doing just routine private practice? You know, it's really going to be like any other program you're putting in. You got to think about what are the type of services you're going to be providing. The other thing you need to consider is the equipment. Your upfront equipment does cost money. There is an upfront cost to setting up a telehealth program. However, study after study shows that over time, particularly when you do quality looking studies, looking at both direct costs, indirect costs, quality of life measures, and so forth, that there is a tipping point that telehealth does become cheaper. And what's really helped with the cost is the decrease in cost of equipment going forward. So it's been shown over and over again that over time, when you do carefully assess programs, that over time CVT is actually cheaper than in-person care. And your tipping point, your return on investment or ROI, is really depends upon what type of program you're putting in. A more complex program, the long and more upfront costs on equipment, the longer it's going to take for you to put that reach that tipping point. So there's a nice paper on that. There's lots of papers on there, and once again, I can always offer more, answer questions and so forth. Let's move on to the next slide, please. Okay. Ethically, it's just too risky to do versus in-person care. I get this one a lot too. And I would really call your attention to this reference. I don't know if you guys ever try to read ethics papers and things around ethics. That's another really complicated topic for me. I'm just a simple public school product, and I can get lost really quick in ethical, philosophical healthcare issues. So I really like this paper because it lays it out into 6 domains to consider when you're setting up a program, and things you want to think about when you're putting together a competent, ethical program. So point 1, competent care. Well, basically you want to make sure everyone's really trained well, has the right equipment, have developed skills and competencies, are able to handle emergencies, safety plans, and we'll be talking about that next week, by the way, setting up and safety plans. So that's one thing. You want to make sure people are really well trained before you go. Then you want to make sure the patients are really well trained about what they're getting into. So there needs to be a quality informed consent process. And we'll review that in more detail next week in the setting up and safety planning talk. You want to educate patients, and you really want to do a quality informed consent around that matter. And there's various templates you can use to help you with that. Managing boundaries, easier said than done, quite frankly. You want to be able to be providing consistent communication across all forms of technology you're using. These days, you got to be super careful with social media. When we were starting, the VA gave us permission to use all types of social media in different modalities at the start of COVID. And one of our psychologists set up a fake doctor account on Facebook. And that was a disaster. The software on Facebook immediately started trying to friend everybody, therapists, other patients, co-patients. We had to shut that thing down immediately. So be really careful with social media. Be careful with intimacy issues. Set your boundaries. Suddenly you're working at home. Suddenly a patient calls you after hours. What are you going to do about that? What about emails? How are you going to respond to those? What about phone calls? Suddenly you're setting up these telehealth appointments. Are you sharing your personal contact with the patients? You got to be really, really careful about the boundaries and intimacy issues and unusual office hours. You want to make sure privacy is in place. You want to be, whenever possible, using encrypted HIPAA software. And if you're not, that's going to be important for you to document and review in your informed consent. And then a couple other things. Let's skip ahead to health equity first, and then I'll touch base on the continuity of care because that's really important. The health equity kind of references back to the previous slide. Access is really related more to income and other educational levels, racial issues, minorities. And so what are you doing to make sure everybody is having quality access to the care you're providing? That's something you really need to think about. Continuity care, this is super important and not to be taken for granted. One thing we've found that, particularly in doing a lot of work for people who are teleworking now, is that this work can get lonely real fast. And you can't count on developing collaborative, collegial networks like you do when you come into the clinic. Suddenly you're not meeting around the coffee pot. Suddenly you're not having lunch together. Suddenly there's not a noontime conference. And suddenly people can start feeling pretty isolated. And that can sometimes people can, start making decisions that are just not wise ones because they're not getting that good feedback from each other. And also you can lose. So we have gone through proactive, conscious efforts to create communities of practice, communities of care that really try to link everyone together. And I think that's really vitally important. Just don't assume people are connected. Create spaces for case conferences. Create spaces to review information and latest policies. Create time to just come together and get support. I don't think you can take that for granted, and I think that's really an important point. And the other point around continuity care I would mention is that don't lose sight of your referral network. That's one of the great benefits of telehealth and having a disseminated network. Make sure that you maintain contact with your referral base. Next slide, please. Patients and providers are not satisfied. Oh, this is so not true. Not true. The literature in our experience has really been shown that patients and providers actually really in many ways provide, not entirely, but in many ways, things you wouldn't have thought of, do prefer clinical video teleconferencing. And what we're learning is that you can have quite an empathic relationship. And a lot of that is because you've got greater eye contact with the patient. You hear all the time, now of course none of you would ever do this, but hey, I felt connected to my provider. They didn't have my back to me and were typing on the computer the whole time. Also, they'll talk about, there's less power differential. There's no anxiety related around that white coat being in somebody else's professional office. You do have better access to specialists, reduced travel time. I mentioned the decreased power relationship. And another thing we've really found interesting, and we're actually looking at some data around this right now, is that this is just a great format or vehicle for vulnerable patient populations, vulnerable populations. For example, we found a lot of our veterans who have experienced military sexual trauma or LGBTQ community much prefer getting care over CVT, and it sort of makes sense. They don't have to come to a facility or an office or a waiting room that could be potentially triggering as well. And we will talk next Friday upon how to set up your waiting room, little tips of the trade on how to improve eye contact, and how to set up yourself in your office to provide this care, and also how to set the patient up to have a professional encounter. So just a little tease there for next week's talk. Next slide, please. Okay, here's another big one. Only stable patients should be treated with CVT. All right, so this could be its own talk actually on its own. And if we get feedback that people want us to dig into this topic in greater detail, we'd be happy to do so. So basically, who's appropriate for telehealth and who's not appropriate for telehealth. So for the longest time, the myth was, oh, you can only see stable patients. Don't dare see, they got to be stable before you can see them over video. Well, our team has purposely been trying to push these myths and push these boundaries. So we started basically seeing anyone referred to us, and we started finding out, well, gosh, we can pretty much see anyone. And so then I would really reference our own Dr. Megan McGinn, who just recently published a great review paper on this topic in terms of risk assessment, complicated patients, at-risk patients, who's appropriate for CVT or not. And so, like I said, there's a wealth of material in this paper, but basically, you can see almost anyone. It really depends upon the structure of your team and your format and what resources do you have. Remember, telehealth is just a tool. It's just a tool. It's not going to make you a better provider, not going to make you a worse provider. It's a tool. You want to use the tool with the right team for the right patient at the right point in time. So interestingly, if you look through this, no, there's been no papers, no RCTs showing that there's greater risk for high-risk patients over CVT versus in person. All the professional boards, there's not a single contraindication to a particular patient class. Um, and we put forth in this paper some best practices. You can do full suicide risk assessments, and you can manage suicide risk. This can all be done over CVT. And actually what we found is we feel like in many ways we're doing a better job because we've partnered with our suicide prevention team who does a lot of phone work. But now when they're working with somebody in a rural setting, they can contact us and we can reach out to them, and vice versa. If in our routine care we come across a rural veteran who is suicidal, we can rapidly access their resources too. So, you know, you can do it. Best practices can be done. So really, so now my opinion, who are those who really we struggle with? Because, you know, if one tool doesn't fit all, not everyone is appropriate for telehealth. We have found that people who struggle are ones with significant cognitive issues, cognitive impairment, history of cooperation, they just can't or won't, you know, do it, ongoing substance use disorders, history of violence, self-injurious behaviors, those that require a lot of medical attention and follow-up, physical exams, vital signs, labs. So in particular, one group of patients we've really struggled with are eating disorder patients. So it works for a lot of people. You just need to be set up. You got to have the right team and so forth. But once again, there's a whole lot of material here. I recommend you check out that one paper, and happy to come back and explore this topic in greater detail. Next slide, please. So this is my last slide before we'll hand it over to the question and answer period. So what other concerns do you guys have about providing care over CVT? And in general, you know, we want to hear about your barriers and challenges and how we can help you get by those, what's working, what's not working. And once again, please provide us feedback. You don't want us assuming for you. We'll switch over now to the question and answer period. Thank you.
Great. Thanks, Brad. That was a really terrific presentation and a lot of great information there that's really helpful to our clinical providers. We've had a number of great questions in the Q&A, and our panel's been very capably answering them as we go along. It seems like the focus is really identifying some specialty populations that our audience really would like some help with, including group therapy, child and family therapy. So the panel can talk a little bit about, this is exactly the kind of input that we're looking for in order to guide the content of some subsequent sessions, and even the sessions that would follow up, kind of a deeper dive after these eight
Sure.
session series.
Sure, I can quickly touch base on the group question if you'd like.
Yeah, why don't you go ahead and say, if you want to say something briefly, we have a couple of open questions too,
Okay,
just about the content.
I'll pause on the group then.
Because I think some of the questions that came up are really around just being able to, within a context of a session, be able to send forms or copies of workbooks, or even using testing tools. I assume that's kind of neuropsych testing, or even kind of more straightforwardly, just the validated instruments like the PHQ-9 or the GAD-7. Can you talk a little bit about how you incorporate materials that you would use in a face-to-face session into a virtual visit?
Absolutely. That's a fantastic question. That's really key. And that's something you want to think about ahead of time. How are you going to relay information back and forth to your client? So there's a variety of ways. If you've got a secure email system, and a lot of healthcare facilities have that now, that's a great way to do it. So you would send them the material you would like them to complete ahead of time via email, and then they return it to you via secure email. So that's one way to do it. Some of the technology platforms that you have allow you to exchange it in real time, and you can share documents, you can share a screen, and you can work with it that way. That works as well. There's always snail mail, but that sort of defeats the purposes. And when all else fails, just hold the document up to the screen. That actually works pretty well. And or you can read the questions straight aloud. So let's say you're doing a PHQ-9, you can just read the questions straight up to the client, and they can answer it, and you can fill it out right then and there. So the ideal way is to have a secure platform that you can exchange that material. Not everyone will have that, I understand. The next would be to look at the tech platform you're using, see if there's a way you can share screens back and forth. The third option would be to read it aloud or just hold it up to the camera. And then I guess the final option would be snail mail.
Great.
Thanks, Brad. Lydia, I'm going to jump in. I do have a raised hand. It's been up for a while.
Go ahead, Melody. Yeah.
So the raised hand is Elsa Daly. I'm going to unmute you.
Hello, Elsa.
Hello.
Hello. You're on, Elsa.
Hello.
Yes.
Hi, Elsa.
Yes.
We can hear you.
Oh, sorry. You're asking me something?
You had raised your hand. I think you also typed in a question, so maybe that was answered by some of the panelists. Did you have a further question for Dr. Felker? It's your chance, Elsa.
Okay. I guess for me, it's I'm a certified peer counselor, and for me, I represent advocate for the family, and we have come across to the point to where it's coming to the intensive, because we do intense-based strength program, that the families that are having to deal with the family therapy portion, they're not able to get the full services for the child unless the parent is involved. And so the parent is involved, but unfortunately, the therapists are not able to address certain things because it's through video. So like I understand earlier, the gentleman saying that, yes, it would most likely be better to be able to work in person, right? But because of what's happening right now with the COVID-19, it's difficult. So what's happening is the parents are starting to feel like that's their own therapy session, which is causing there to be
Elsa, this is Lydia Chwostek. That's a fantastic question, and it is such a huge topic. I think I'll give Dr. Felker an opportunity to respond to that, but I think I just want to point you to some resources on our MHTTC website. We have a school mental health group that has been very active in working with supporting families. It's not exactly the question that you're getting at, but this is exactly the kind of thing that I think we want to explore in more detail. So as kind of more specific sessions focused on this, because this is a huge problem. So we appreciate you bringing this up.
Briefly, if I understand the question, it's you're not able to observe the child's behavior, and the parents are so frustrated they're just seeking their own. Some of the child psychiatrists I know who have commented on that, and they've found that what they do is do home-based, and they actually can get a wealth of information by seeing the environment that the child's living in, the house, the way the parents interact with the child playing in the background, and so forth. So you might want to recommend a home-based approach.
Okay.
Elsa, there's also a lot of information coming out from a group related to first episode psychosis treatment, which involves family psychoed. So we can also direct folks to again on our website or to the National MHTTC website some materials related to support of families. But terrific question. I think we have another hand that was raised, but let me just ask Brad the quick question about, are there opportunities to use telehealth for specialty care referrals or referrals to a social service with a warm handoff during a visit?
Yes.
So I imagine that would be you and another provider, and how does that work?
Yes. Sure. So a lot of these video platforms now, you can be working with somebody one-on-one, and then you can real time invite somebody into your virtual room. So the way it usually works is the provider will lock the room to keep people, around confidentiality and stuff. And we actually do this in primary care now. Virtual primary care, integrated care, is you'll do a warm handoff, and you can invite people into the room. So you can invite the specialist to come into the room, and then someone can leave the room. So it's a virtual space, and you can control and lock who comes in and out of it. Mm-hmm.
That's a great. I just want to draw everyone's attention. I know we have 10 minutes left. Rebecca has put into the chat the survey, and just want to draw people's attention to that as we're continuing with the Q&A. If people would take a few minutes to also complete the survey, it's very helpful for us for our tracking purposes, but it also gives you an opportunity to ask some more questions and give some feedback into the direction of this subsequent sessions to this series. Just so everyone's aware that the survey is anonymous. You're asked for a unique code for SAMHSA data tracking purposes, but this is not, your data is not going to be connected to you, and you'll never be identified. So please take some time. Yeah, please give us feedback.
Do you want me to jump on the group question or keep going?
No, there's a question about the accuracy of substance use disorder assessment via telehealth. And I think that's the question is about doing it without video. So if you're doing a substance use disorder assessment on the phone and not with video, but Tana, Seiler, if you want to, if I don't have that right, yeah, please clarify the question. But it's a good question just about substance use assessment with and without video. You talked about the validity of diagnoses. How about for substance use disorders?
Well, having the video component is just another layer of information that you have to evaluate. So yes, you can, it's stepwise, what you get in the mail provides you some information. Phone provides you more information. Audiovisual gets you even more information. And then on top of that, you can actually get peripherals now, like breath analyzers that they can blow into, and that information, can be, so there's peripherals you can set up and send home with people. So there is technological actual extra things. You can get blood pressures, you can have breath analyzers, you can do all kinds of things. So it's sort of a gradient. The more technology you put into play, probably the better assessment you get.
Great. Hey, and I just want to circle back to, I think you already answered these questions, but I wanted to just make sure Blake Johnson had asked about the forms and the workbooks and the testing tools. I just want to make sure that that Dr. Felker's response was, so Blake, please feel free to chat in if we didn't answer those questions, because I think there's a lot in the questions about different kinds of workbooks and testing tools.
I do see Blake said something about UAs. So yeah, this is why you often will still need to partner with a lab, particularly since I'm a psychiatrist and I do need to get blood work done, and I do need to check UAs, and I do need to do screens and things. So we're not to that point yet, technology wise. So when you're thinking about your program, you're also going to want to think about, once again, your referral network and your community assets and resources.
Hey, the one final question we have is just to kind of follow up on the substance use disorders and the challenges that are specific to those kinds of visits. I think this gives us an opportunity. It's a huge topic, so thank you for that question. It's specifically that, are there particular difficulties related to substance use disorder treatment via telehealth? So our panelists can take a crack at that, but I also want to alert everyone to a webinar that's coming up from our partner organization, the Northwest Addictions Technology Transfer Center, which I believe is next week. So if Christina or Gabrielle can just we'll certainly be on our website, but our partner organization is really going to focus on supporting telehealth for substance use providers. So great question.
Well, right off the bat, one thing, I would say with substance use treatment over tele, and this is a broader topic that maybe we'll touch base in a future time on treatment is the prescription of controlled substances such as buprenorphine over the internet. That's a controlled substance, and there is very specific rules upon how you can and cannot prescribe any controlled substance, be it buprenorphine, methylphenidate, narcotics, and that's a whole topic in and of itself. I can't do it justice. So just be careful. I would advise everyone be very, very careful about any prescription of controlled substances until you understand the Ryan-Haight law.
I think that's a great way to end, Brad. I think we might be thinking about, you know, what are the most helpful topics for participants for this series to focus on. And I think prescribing of controlled substances is an important one. And the other topics that we hear you bringing up are the attention to family and family therapy, and the treatment, the provision of child psychiatry and psychology treatment. I do also want to acknowledge that that there were a couple of questions that have related to the Zoom licenses that are coming from HCA, and just wanted to let you know that our panelists will get the questions answered just about accessing licenses and laptops and other technology, and just confirming how you know that you have the Zoom. We saw one about how will I know that I have the HCA Zoom. So we'll be posting answers to those questions. I think we'll kind of move on and wrap up. We just wanted to thank everyone. Thank Dr. Felker for a wonderful presentation. Wanted to thank everybody for joining, remind everyone to fill in the survey, because this is really important information for us. You can find out more about the Behavioral Health Institute through their website, or emailing Melody, and kind of the other activities they have in store for technical assistance. On the next slide, I think you'll find out just more information about the MHTTC. We can go on to the slide that's just reminding you about the survey. There's our website, www.mhttcnetwork.org/Northwest. You can follow us on social media or email us and find out about upcoming trainings and new online trainings. So just again, thank our wonderful presenter, Dr. Brad Felker, and the panelists for all their work in answering the questions. Thank everyone for participating today, viewing the webinar, and taking time to learn more about this important topic. And reminder that we will have our next session on next Wednesday. So wish everyone a good weekend. And just noticing the final question is kind of sharing of the link to our website and all of our resources related to COVID-19. We absolutely will do that, and we appreciate the additional resources that some of you have chatted in. And we're really open to any feedback you have about additional resources that can help clinical providers in this time of transitioning to telehealth. So thank you so much, everyone, for participating, and thanks everyone for and then thanks to our panel.